Thank you, Dr. Good evening, colleagues. My name is Hamid Tohir. I'm the Medical Director at the Khan Hospital, Mombasa. I'm a pediatrician, a pediatric nephrologist by background, and I'm looking forward to this discussion.
Okay, thank you very much, Daktari, all the way from Mombasani. Let me still stick to the coast. So, Josfrida, if you could introduce yourself.
Hi, everyone. My name is Josfrida from Kilifi County. I'm an emergency and critical care clinician, currently working in the isolation facility of the COVID-19 patients, and looking forward for a lovely discussion this evening.
Thank you, Josfrida. I believe the person next to you is not your bodyguard.
Definitely not. Let him introduce himself, please.
Okay, please.
Yes, good evening, everyone. My name is Dr. Edin Zomo. I'm working as the medical superintendent of Kilifi County Hospital and also dabbling as a frontline worker in this COVID pandemic. So I'm looking forward to a fruitful discussion. Yeah.
Thank you very much. So we see Kilifi has tag teamed, and because they have tag teamed, let me now then introduce two individuals who are in the frontline or emergency response services, and I will start with Miriam. Miriam, if you could introduce yourself. Okay, Miriam doesn't seem to have gotten me. Jerry, if you can hear me.
Good evening, everybody. My name is Manere, currently the clinic manager at Amref Medical Center. I'm a critical care nurse by training, and also a student at Strathmore doing MBA healthcare.
Okay, thank you for the shout out to the Strathmore alumni. Miriam, if you're able to hear me now, this is your chance to introduce yourself.
Thank you, Dr. Ngoye. Good evening, colleagues, friends. My name is Miriam Bembe. I work for Kenya Red Cross as the head of the department they call Health, Nutrition, and Social Services. I'm a public health specialist by orientation.
Okay, great. And so we have one more, and this is Emma. Emma, if you could kindly introduce yourself.
Thank you. Good evening, everybody. My name is Dr. Emma Wyah. I work as a medical advisor to Farm Access. My background is that I'm a medical doctor and I have an MBA from the University of Oxford Business School side. And I'm happy to be here for this conversation today.
Brilliant. Thank you. And I am the choir master or conductor, if you will. My name is Ben Ngoye. I have a background in clinical medicine, in public health, and many other things along the way. But for today, what is important is that I will be trying to be your moderator. And in this sense, what I want us to do is to have a really interactive session. So you, the participants, what I will ask of you is feel free to make use of the chat function at the bottom there to put up your questions. And we will be picking these questions as we go along and trying to answer them, particularly if they fit within the theme of today's discussion. Now, today's theme is on experiences in the response to and management of the COVID epidemic. But like I mentioned earlier, it is the second of a series that we began in the week past. And so last week, being the first session that we had, we spent a couple of minutes just having an overview of SARS-CoV-2, SARS-CoV-2, which is the virus that causes the disease known as COVID-19. It is called, the common name for everybody is coronavirus. And the reason why it's called coronavirus is because this sort of like halo-like thing that it shows when viewed on electron microscopy. It is not an entirely, coronaviruses are not entirely new. They've been there since before. What is new is this particular strain. It is seasonal in nature. Its transmission is airborne. More often than not, it causes mild disease, but this particular strain seems to cause severe disease in about 15 to 20% and of those that it infects. And so just like flu viruses, it is a disease of a public health concern. Now, after presenting that overview of what it was, we then delved into the core of that session, which was on behavior change communication strategies. To sum this up, okay, since the whole thing of coronavirus has begun, we have been hostage to a lot of misinformation or wrong information being passed through, some of it from ill will and some of it because WhatsApp has granted us a number of PhDs. And so we get information that we confuse for knowledge and we quickly pass them on. The other bit is that we have the right information that is poorly packaged and therefore it is not represented or acted upon by the public in the way that it should, or it is the right information but we make use of the wrong channel. And so the reaction or the reach of this particular message is not what was expected. And so the sum total of that conversation is that we need to properly understand the disease, understand the life cycle of these epidemics, point number one. And point number two, it is very important that we go back to the basics, make sure we have the right information, package it in the right manner, make use of the right channel, and make sure that we actually target this information to the right audience. The reason why we say this is because audiences differ. We don't have anything called a general population in public health. And therefore, messages should be packaged or tailored for these audiences. And secondly, the messages should change with the evolution of the epidemic, okay? So in a nutshell, colleagues, guests to the webinar, this is what we talked about last week. Now, that being said, today we want to talk about experiences with regards to particularly frontline worker experiences with regards to this epidemic. And to kick us off, I will ask probably each of my panelists just to share with us a little bit what their experiences have been, maybe in terms of facility preparation or readiness in acute care or as a first responder or on the community front lines. Dr. Twahir, maybe I would start with you on this one. What has been your experience, particularly in terms of how Aga Khan was able to organize itself or make itself ready to handle this pandemic from when we first heard of it as arising from Wuhan?
Thank you, Dr. Terry. Just a bit of a background so that you can understand where we're coming from as a hospital. We're one of the oldest hospitals in Mombasa, very limited in terms of space. And I'm going through this deliberately so I can prepare you mentally on how easy or difficult it was for us to try and prepare ourselves for this pandemic. Fairly small, 82-bedded hospital. As I said, first built in 1944 as a maternity hospital. Indeed, if you remember, one of the first case in the country was on the 12th of March, and we actually had our first case on the 20th of March. So not very far from when we first reported it nationally. So preparing ourselves for this pandemic in a hospital that has limited space was not a very easy task, but we leveraged on the network. So if you realize Aga Khan has the network, it has Aga Khan University, Nairobi, Kisumu, and Dar es Salaam, and that allowed us to share some of our experiences. So it was not very new when it came to handling the pandemic eventually. One of the first things that we prepared ourselves was to prepare ourselves to try and meet the demands of our clients. How do I say that? In the sense that we anticipated that we would start seeing patients being the second capital city. So one of the first things we did was to prepare our triage area so that we could actually easily identify our patients right from triage. So we actually moved our triage to a place called pre-triage. And I think a lot of institutions are now beginning to do exactly the same thing. So we like most hospitals, our triage is within the hospital. So for the first time, we took our triage outside the hospital, very near the gate, so that we try to identify these potential clients before they come into the hospital, for two main reasons. One, so that they could be cohorted and put into the right place. And the second reason was for the safety of our staff. And time permitting, I'll say why we were so keen on safety a little bit later on. So we initially, it was a history of travel, history of fever, and cough and sore throat. Eventually, right now with the community spread, is anybody with a history of cough, fever, and any flu-like symptom is actually taken through a flu or fever clinic before they enter the hospital. And that allows us to prepare ourselves mentally and physically in terms of our PPEs so that we don't expose our staff unnecessarily. The second part was to prepare our staff, as I said, so that they don't get infected. So if you were to come into a hospital today, you'll actually see all our staff putting on a standard universal PPE. That includes a gown, a headgear, a footgear, and a mask. And depending on how we pre-triaged you, then we will actually step up our protectiveness. The last part of our preparedness was to identify an area where we would actually be able to isolate those who now tested positive. So as I said, it was a small hospital. Unlike, for example, Aga Khan Dar es Salaam or Aga Khan Nairobi, where they could divide their hospitals into a non-COVID and COVID areas, we actually had to identify an area within the hospital. So that increased our risk profile a little bit, but then we had no choice. We still had to prepare ourselves. So we had an area that was freed for renovation, one of our semi-private wards. But we had started, as any good hospital, we had already prepared ourselves for isolating infectious diseases. So there was if you remember, there was the Ebola threat some time back. So we had 2 rooms that were already prepared for negative pressure. So we were not so far behind when it came to COVID. But then we realized that we needed to prepare ourselves more than the 2. So we identified the area closest to the 2 isolation areas or isolation rooms, and that was the semi-private. It was a journey, so that's how I would like to describe our preparedness. Every single day, including today, it's a learning experience. We had no proper donning and doffing areas, so we had to create these areas. We had no proper access or to that area, so we had to demarcate our isolation so that it's actually free from the rest of the hospital. And then recently we had an experience from a patient who was actually COVID positive, but then was actually had withdrawal symptoms, alcohol withdrawal symptoms, and was disorientated. So actually found himself outside the red zone, outside the isolation area. So again, being a journey that we had embarked on, we now had to create or prevent access for some of our patients from coming out of isolation, keeping in mind the safety of these patients. So to summarize, I would actually say it has been and it is a journey. Every single day allows us to try and prepare ourselves for different scenarios. So
okay.
Yeah, yes, Terry. I was just about to say that one of the things that we eventually did was actually to do a drill. And in the drill, we looked at a scenario of a pregnant lady who was actually COVID positive. We looked at a scenario where we had to transfer this patient for possible cesarean section. We looked at a scenario of how to receive the baby. and so on and so forth. So it allowed us to look at different scenarios. And as I said, as we go ahead, we look at each scenario as we meet it, and it has allowed us to grow leaps and bounds.
Thank you. And hopefully you've become better at weeding out drunks and not confusing them for COVID positivity. Okay, now, the experience from Kilifi, because this we were talking about was a private facility, even though small, maybe the kind of resources and the kind of management structures are different. Not maybe, they most obviously are different from a public sector. So what was the experience, very briefly, from Kilifi in terms of preparedness and that initial journey? If between the two of you, you can just share that, but keep it very brief, please.
Okay. So I think Kilifi, it was hard hit because it's where we found the first case from travel. And I think that's the time we're getting the reports from Wuhan that now we have the disease because of travel and stuff. And people are not, yes, we were prepared for it, but we didn't prepare it to come to us as fast as it is, because now our problem would be one, testing positive in the community. So we were worried of local transmissions at that point. So I think as a facility, we had already established one of the facilities, which is Jibana, to be the isolation center for the COVID-19 patients. And we had already run drills in this place, but I think it was more of an emotional moment because one, as a health worker and a frontliner, you're not sure what you should expect in this new pandemic that none of us has experienced before. So it was a new thing. And I think for Kilifi, now we, from that point, we focused on contact tracing to be able to actually get the numbers of the people maybe would have gotten the local transmission from our first case as it was. We had 2 ICU beds in that facility, and we had about 8 beds in that facility for the first isolation cases as we were trying to man up the other facilities for keeping these patients. So in terms of staffing, we already had staff who had done drills in those facilities to be able to see how best, if the patient comes in, how we're going to receive them. And I think our first patient came in the night, and this was because of from the local transmissions for our patient. It was really bad because there was too much stigma around the patient, and we had to be evacuated immediately to the isolation facility. And being a team lead in that group, it was a bit tricky because you didn't know what exactly to do. But I think as the days goes by, we were able to establish strategies on how to see this patient, how we're going to handle the patient in the facility. I would say currently, in terms of ICU and acute care of the patients, as a county referral hospital, we've never had an ICU facility. In Mombasa and maybe Aga Khan would be our referral centers, but for this time round, I think we were preparations were done in such a way that we were able to procure ventilators and have cardiac monitors to be able to face any challenges that would maybe come out in cases our patient will become critical in that care. So I wouldn't say we are really safe, but so far we don't have any new cases in Kilifi. And the cases we had, we've already discharged. We had a total of 10, but 4 of these patients were from travel, and their usual residence is in Kilifi, but they were placed in Bagathi for their isolation. 6 were majorly local transmissions, and as I can tell to date, we've discharged them and they're doing well at home.
Okay, you mentioned something interesting. If I can just stay with you for a bit, that you sort of had to develop strategies. So what are these things that you had to develop? Are they things that you imported from WHO? Are they things that came from government? Did it have to come from your own initiative? How did you know what to do?
So these were in terms of WHO, to be able to know the patient flow and how they'll come. So we had a triage area like in the referral center the referral hospital, which was pushed to the main gate. And we had 2 tents at that particular point where the patients would come in and would ask the history of travel, any cough, any sneezing, and also take their temperatures at that point. If we had a COVID-like patient presenting, then they would definitely move to the second tent where the samples would be collected, and maybe there they'll be taken to the designated facility, either quarantine facility or an isolation facility, but there will be a holding area for them to just await the results. As in Kilifi, we're lucky to have Cambry, who was doing for us the testing.
So in brief, you were able to pull on a huge number of stakeholders, both global and local, in order to structure your preparedness, more or less.
Yeah.
Okay.
Yes.
Now, I want to shift tack a little bit. Would have been interesting to find out the experiences of the first responders. But I want to build that in, or no, maybe let me before I go there, let me just ask from one of them. Njeri, what has been your experience? I mean, you are with AMREF, and yeah, what has that been in terms of you know, when you get a call, somebody has COVID or is suspected to have COVID, they need to be moved. After the initial screaming, wailing, and calling all neighbors, what do you then do?
So with the AMREF Flying Doctors, which is an air ambulance company that is able to transport critical care patients. So when the COVID started, there was training, there was purchase of PPEs, but there is one aspect that was not taken into consideration, which is the isolation unit within an aircraft. So when the first call of the Kilifi patients to bring to Nairobi came, there was a bit of delay because no one knew what are the protocols in an air ambulance to transport a patient with COVID. But with consultation with other stakeholders, we were able to bring the patient to Nairobi with full PPEs. But currently, we've been able to bring in a portable patient isolation unit, which is a good gadget that has negative pressure, barely exposes the medical personnel in the aircraft. The patient is in a cocoon, which has filters, it has oxygen supply in it. So you transport them in that cocoon, and that cocoon is disinfected upon arrival at destination. For the other arms of AMREF, the clinic and the community health workers, it was just about the purchase of PPEs and just sending out messages to community health workers about how they are going to rally the people in their community about the disease.
Thank you. One of the organizations that are really community facing and that has really been at the forefront of making sure that any community interventions are well covered is the Red Cross, of course. And so this is the point I would want Miriam probably to share her experiences, but I want to twist this in a little way, Miriam. Community participation or support for many of the initiatives could have been better. I think that is something that we all agree. Okay, we could have been more supportive of curfew. We could have been more supportive of hand washing, social distancing, closures, and all these sorts of things. But you will agree with me that the community response has been very varied. Okay. Varied depending on the location, on socioeconomic standing, etc., etc. Why do you think this is? As an organization that is really in daily and constant interaction with the public, what are you hearing out there? What is their experience of COVID and of the government-initiated responses to this epidemic? Miriam.
Thank you so much. And just to pick up on the experience, I think for Kenya Red Cross, it's good to appreciate that with the network within the 47 counties and working with volunteers, most of whom are not healthcare professionals, must have been a very brave move to take up COVID as a response. And so for us to be able to do that, one of the things that was quickly done was actually to develop, I think then there were not so many guidelines from WHO, CDC, but we developed some training materials and ensured that we had a national level training where we had TOTs that would cascade this training to the counties, the 47 counties, targeting both the volunteers and the staff. And I think that in itself was helpful in terms of empowering the staff and the volunteers. But I would also say it had some form of psychosocial support in terms of where you know that at least I understand something and I can actually confront the community and be able to pass on the right messaging. And so what we've seen all through is that we've actually seen varied participation, and for very good reasons. You can understand where the community is coming from and you can understand where the government is coming from. It's been very important to appreciate that
we don't understand where the community is coming from. So can you just unpack that for me a little bit?
Yes, for the community, it is good to appreciate that the community, and especially knowing that they're coming from a household, they do care about their families. So when it comes to family care, the community has been very supportive of all the infection prevention control measures. And so they would actually they know it, and they want to carry it back to the households and where they're going to. However, they do not live in a vacuum. And the other socioeconomic elements are deterring the community from participating fully. And giving an example, for example, you have a community that is coming from an informal settlement, living in a 10 by 10 square feet of a room with 7 children. You want to social distance. You want to be able to do all the other IPC measures that you want to communicate. This is a mother who has to go to another household in Kilimani, for example, in Nairobi, to wash clothes to earn the 500 shillings to come and feed her family. So basically what you're saying is that the stay-at-home messaging will not go through to such a family. The issue of social distancing will not be a realistic approach to such a family, because in one way or another, this mother has to go out and look for food for the family. So I think for me, it's that Kenyans understand, the community understand the need to actually protect themselves from COVID, because COVID has come with multiple issues, including anxiety that is restraining, because a good anxiety will enable you to do positive things. But this is really restraining them to participate. So you actually realize that we're living in an environment, and we're trying to operate as Kenya Red Cross in an environment where you want to provide right information, which we do. You even provide the hand washing points, you're able to provide the PPEs, but you're looking at the cultural, we are not used to walking around with things on the masks, on the face, the mask on the face. And so you find, when you find Kenyans pulling the mask down at the chin, we're used to smiling, we're used to engaging ourselves, and you can see the whole facial expression. So I think for me, it's just an issue of slowly allowing the adaptation and the changing to a new normal, that we're talking about, the new normal, to be able to accommodate. And the flip side of it is that as the community struggles to adapt to the new changes, I think most of the instructions in some quarters have actually been seen to be like constrictive punishment from a government point of view, especially when quarantine was being paid before the government came in and said quarantine now is free in the government facilities. So you actually realize that because of the environment that is not really supportive to this particular community, you actually would want to give, and you would want to give as much information as possible, but there's a lot of constraint that the community is struggling with, including protection, where they need to have a basic packaging, like this mama can get her food for her children, she can get the face mask provided because she does not even have the 50 shillings to pay a face mask and all that. So I think for me, that is quite a dynamic thing that we need to understand. And all of us in terms of community, if you look at the household, you look at the mother, you look at the father, they're all concerned about just trying to mitigate, reduce infection around COVID. But other elements around the cultural, socioeconomic issues also need to be packaged as part of interventions for COVID, so that COVID does not become a medical aspect per se, but you also look at the socioeconomic interventions around it. Thank you so much.
Thank you very much for, you've unpacked it to its bare elements. But if I could just summarize, basically what you're talking about is the distinction between ability, willingness and ability, or put differently, between intention and action. And that there are certain things that can modify this. One of not least among them being, of course, the economic situation that one finds themselves in. Not least, of course, being the social situation where one finds themselves in. For example, when we are talking about issues to do with congestion and stuff like that, not least being the cultural dynamics and what this would mean, okay? So the big idea here is how do we move from this intention to behave or willingness to support a particular initiative to actually getting to do it. Now, let me turn back to the participants and just to encourage all of you who are participating in the webinar to please make use of the chat to share your questions. I have a few that I have just printed out from that were asked a little bit earlier as people were registering for the course. And I will put maybe if at this point we just talk about the ones that are related to medical care. There are 2 or 3 of them that relate to treatment. One is what is the effect of retroviral drugs on COVID-19? Another one is the cure from Madagascar effective? And the third one around treatment is, are there hope? I think the author must have meant, is there hope of getting a vaccine for COVID-19? The guys in the medical facilities, what can you say? Those are quick answers.
This is Dr. Tahir. Let me chip in by saying that if you look at least the vaccination process, and you may have heard a lot of how vaccines are developed. It's usually a tedious and a very prolonged process with several trials. So there is hope of getting the vaccine. And a lot of people have talked about where they have reached as far as the vaccine participation is concerned, but naturally it will take some time. How much time is debatable. Some people have talked about between 6 to 12 months. I would go towards 12 months. So that I would think the earliest we'll probably see a vaccine would be towards the end of the year, perhaps, if not early next year. As regards antiretroviral and other medication, remember a lot of what has been talked about as far as treatment is concerned is supportive care. People have used monoclonal antibodies, tocilizumab. There is discussion about the use of remdesivir, an experimental drug that was initially developed for Ebola, but didn't show very good signs in terms of outcome. But people have seen that there may be a role in COVID. So I think it's what is being used is I mean, only time will tell. Our experience in Aga Khan is that we actually use tocilizumab in our patient. And I think the clinicians at least who handle this patient feel that it may have made a difference. This patient came in severe distress, had many comorbidities, but after 2 doses following the protocol for such use, the patient was actually discharged 2 days ago. So I know people will have different comments as regards this particular drug and many others. But that was our experience in Aga Khan. In other areas, they will actually just do supportive care, oxygen, nutrition, physiotherapy, and actually wait it out. The use of hydroxychloroquine, again, a debatable issue. But we'll, as far as antiretrovirals, I think my comments is on those 2 drugs. And fairly good outcomes on our side as far as tocilizumab is concerned.
Okay, thank you very much for sharing that. Just to to reiterate a couple of things that that you have said. Number one, I think that it's very important for us to understand that vaccine development is a very long process. You know, starting from when new antigens or immunogens are developed into, you know, are identified, and then how that is developed into a level that can be evaluated through preclinical and clinical studies, which in themselves have several phases, takes a very, very long time. Partly because this is highly regulated and a number of questions need to be resolutely answered, you know, questions around safety, questions around efficacy or how well the drug works, questions of the development and manufacturing costs and who is going to do that, because that will affect the accessibility of the drug to the public. Issues around storage, administration, and all these sorts of things. So all these are things which cannot be isolated from the process. And so it will be very difficult for us to hold our breath right now for a vaccine. The best hope that we have right now is in matters prevention and matters of symptomatic management. Now, on the other two things that were asked, it's important also to reiterate that, you know, to be very honest, there's no definitive treatment or therapeutics for this. So whether we're talking about retroviral drugs or whether we are talking about the cure from Madagascar, as was specifically asked. And I know prior to Madagascar, there were stories around garlic, then it became turmeric, then now somebody's boiling pawpaw skins. You know what, all these things are going to be there. Suffice it to say, however, that there is room for symptomatic management, and which is normally what all of us would do, you know, take your fluids, you know, if you have fever or congestion, there's a way of managing that, you know, bed rest, pretty much being able to wait it out. There's another question that has been asked by a participant, an earlier participant, and I want to take this to Josfrida, who is in acute care. And the question was, have you had to remove a ventilator? I mean, you can repackage the question, but the question as it was stated was, have you had to remove the ventilator from a senior patient to someone younger? As we have been hearing, people have been doing abroad due to critical demand and limited supply. I want to believe that the author meant of these ventilators. This is basically an ethics question. So you may not have been able to do it, but hypothetically speaking, what would you have done, Josfrida?
Yeah, I think there are a lot of ethical issues involved in that case, but I'm very sure if it was in a case like in critical care, normally what we do, there are various considerations you'll make, either to put the patient on a ventilator or not to put them on a ventilator. And when also you decide when your goals of care for this patient are not going to be beneficial, even if they still stay on the ventilator. And if I should just reiterate, I think the cases in the UK, most of them were very elderly patients. And my thoughts would be them being on the ventilator, they'd make them mostly, the immunity is quite low, and they should, if you put them on the ventilator, they could become ventilator dependent, and moving them from the ventilator would become an issue. So I think maybe the team there would really have thought on what best suits this patient, whether being on the ventilator or not on the ventilator. So there's so many, when it comes to critical care, there are really a lot of issues they look into as pertaining the patient for them to be either on ventilator or not ventilator. And also as the studies are going through, you'd find that most of the patients, the COVID virus seems to attack more on the heme part of the red blood cells. And it has shown that the patient will benefit more from multiple transfusions compared to being on the ventilator, would even worse the patient's condition. So I think there are various issues that would have been taken into consideration before agreeing on which patient stays on the ventilator and not off the ventilator. That would be my take on that.
Jerry, you've been called to Kilifi. Who do you take? You have two clients. One is 5 years old, another one is 71. who boards the bubble thing that you are describing of the aircraft? And who do you leave behind to come by RGR? Is it SGR, RGR, whatever?
Yeah, fortunately, the aircraft has 2 stretchers, so would basically carry
okay, so there are 3
2 patients. So 3, we'll go for them at a time. We go for 2 first, then the next one, because unless the patient has indicated and signed do not resuscitate or do not do advanced critical management, then you do your best depending on the resources that are available. So maybe would relieve the Kilifi hospital from the 2, then maybe the next day pick the other, until the patient is willing to sign a clause, because it's against the law not to do the best for the patient. There is no law in Kenya for mercy killing, which I would name it as that. So, but in Kenya, fortunately, we've not reached that point that we have to negotiate on who will share the ventilator, because the critical cases are very few at the moment. And the hospitals have been gearing up to equipping with ventilators, even home, there are innovators who are doing ventilators locally. So we still have some room to get to that point.
Okay. So the way that was a trick question, because at the root or the heart of that question is actually an ethical issue. Now, the first thing, we need to be sure that we separate ethics, which is usually based on values and reason, from morality. Yeah? Because sometimes I find that when people discuss ethics, what they mean is, and vice versa. These two are very different things. Now, unfortunately, in such situations, there's actually no preordained answer to any ethical dilemma. Each ethical dilemma has to be judged on its own merit, and it's usually not an easy thing. For medical ethics, the common recourse would be the 4 guiding principles. And the first principle is autonomy, of course, of the patient to be able to make decisions. The second one has to do with justice, which draws from you in terms of you as the carer, in terms of ensuring that any benefits or any risks or whatever are shared across. The third one being the idea of beneficence, doing good, pretty much, that is what that means. And then the fourth one being non-malfeasance, or basically doing no harm. And as you can already see, that there's a tension between even these principles themselves, because on the basis of autonomy, I could say, do not resuscitate. But as Njeri has rightly shared, I mean, it's a challenge because there's no law. What is going to prevent somebody from saying, if you do not intervene, that you participated actually in the demise of that person? So in brief, okay, there's no preordained answer to that ethical dilemma, but these are the principles that that we would have to deal with. Okay. I want to bring on board, because quite a number of you have mentioned the impact that this has been having on frontline care workers, and I want to ask Emma at this point, because PharmAccess has been dealing with issues of capacity building and training and institutional system strengthening issues. What can we do? What can we do so that we can better support our first responders, our frontline care workers, even as they, take on this giant role of taking care of the patients?
Thank you, Dr. Penn, for that question. I think that to be able to answer that question, I'll give a bit of background to how PharmAccess works. We really work to support and strengthen the healthcare ecosystem, both from a supply side and a demand side. So in terms of the facilities and the frontline healthcare workers, I think what we've done from a safe care perspective is to be able to identify the knowledge gaps that you're describing right now and how we could build to support them. and we were able to identify that the gaps were essentially in the emergency preparedness and infection prevention and control programs in hospitals. And through that, we drew from our quality standards and developed a healthcare, safe care hospital preparedness checklist that has actually helped hospitals be able to identify their gaps and self-assess and be able to plan on improvement strategies, right from the administrators through to the frontline staff. In terms of protecting the frontline staff, we truly believe that PPEs is a basic requirement for all the people who are interacting with these patients. But it's a global problem. It's not just a Kenyan problem where we have a lack of PPEs. So I think our position on that is that regardless of that situation, all healthcare workers should be provided with adequate PPE. To that end, what we've done really is work on the National COVID Response Team to be able to help the government identify vendors who have quality products that are not compromised, to be able to avail those products to healthcare providers. So more as a linkage to the right product. And also we support what the government is doing in terms of supporting local manufacturers to develop their capacity to put out the same PPEs for our healthcare providers. Yeah, thank you, Ben.
Okay, thank you. And I believe you have answered what Naomi has posted there on the chat. So Naomi Njuguna's comment was, or question was, have protocols and sensitization programs been developed for home management of asymptomatic patients with mild symptoms? And how can frontliners participate in this? No, you might have mentioned that, or you might have skipped it. Do you want to take that up? And then I'll also ask Miriam to comment on this.
Yes, I can take that up. Part of these protocols for management of asymptomatic patients have been developed by the Ministry of Health. But what we've done as Safe Care is more help people understand how to prepare for infection prevention and control. So even in your home, how would you prepare an isolation center? How would you prepare a room where the patient can be able to stay and not interact with the rest of the family? And this has helped in terms of infection prevention and control.
Mm-hmm. Okay,
yes. Yes.
Thank you. Thank you very much for that. There's another question here from Henry Omtata, who asks, Kenya's COVID death cases seem to be rising and should be something of much concern, as some of our neighbors like Uganda seem not to have any death at all. What have they got right that for us seems to be complicated as we keep losing our COVID patients? Who wants to take that up? Anyone who raises their hand, I will pick. Are we having more deaths than the other countries? And the question is, why? Yes, Dr. Nzomo, go ahead.
So thank you. I think the government and the facilities have really tried, and also our media houses in passing the message on hand washing and the different strategies that have been put. So remember, we are now in day 12, I think, of the cessation of travel again. So you can see that the government has tried to put measures so that to curb issues on COVID-19. But nevertheless, as we all understand, I think currently we've also started mass testing. We might not have optimized it, but the numbers that we are testing currently have gone higher, and we expect through that we're going to get more cases. So for the deaths, I don't really think that our numbers are really rising, but we also expect that because we've increased our testing capacity. And as we all know, that most the elderly, because those who our mortality has been on that age group of 55 and above, and we all know it's because of that age group is more exposed to comorbidities because of their age, and also that risk of reduced immunity. So I think that is the reason that we've had the more cases, but not because we failed to put strategies in places. Yeah, so I think that's my contribution.
Thank you. So in brief, what determines the outcome is dependent in part on the severity of the infection, but also you have what are called patient or host factors, the comorbidities that Dr. Nzomo is talking about. And so issues like the extremes of age, we know are particularly challenging when one has the coronavirus. So meaning the very young and the very old, number one. Number two, the immunocompetence or suppression, which could come when somebody has, say, for example, cancer and you're taking medication, or you have a kidney ailment, you are on things that are suppressing your immunity or whatever it is. So those ones generally would tend to have poor outcomes. So we have to go beneath the numbers. Like I said, in medicine, it's very, very difficult to have very general, this kind of generalizations. When you go beneath the numbers, then it is possible to understand. An example, a good example would be, as somebody had asked in the previous forum, what is the issue with Italy and Spain? But you see, when you understand that these are two countries that have two things in common. A, the populations are inverse in the sense that they have very many old people, and most of them have 2 to 3 comorbidities and they're living with them, number one. And number two, the degree of contact that they have, because these are highly social communities in comparison to some of their neighbors, the Austrians or the Germans or the French, you know. So it is very common to have the extremes of age meeting on a regular basis. And so infection is far much more, and therefore that would be able to explain the numbers, okay? Okay, there is a question that has been asked here that has to do with, say, for example, taking us back to the communities. I want to package this for the team in this sense. We are already seeing a number of issues coming up. Issues such as stigma. I believe you mentioned this, Miriam. Okay. Issues such as cost or ability or, you know, to pay or empowerment. And then there's also issues around mental health, okay? To what degree, because these are some of the things that are now arising as we start moving away from the emergency phase of response. To what degree are we prepared for this? And I would want to link this with a question from Christina, who is talking about home-based care, you know, care of special populations. Because as we move away from the emergent, we now need to start thinking about this long-term. So Miriam, community facing. What are your thoughts around that?
Yes, thank you. And thank you so much for the question. I think it's good to appreciate the fact that COVID-19 itself is really a gray area for us, I think, globally. It definitely comes with anxiety, with uncertainty, limited social interaction, and even the incoming of COVID did not stop the other sicknesses. So we still have the Homa-like sicknesses, and today if you have Homa, you would definitely self-stigmatize because you would think everybody feels I have COVID. And so we are living in a scenario where we actually are filled with anxiety, filled with fear, and sometimes the stigma starts with us, because then if I had symptoms that look like COVID, but it's the regular infection, then I feel I shouldn't even go for medication. And so what we're realizing is that we also are having a lot of mental issues coming in, and mental issues are coming in because first is that the healthcare system, the continuity of service has actually been interrupted in a way, because not everybody is now free to go to the healthcare system to seek support. We have cases of loss of jobs, and you've seen that a lot. There's the case of social isolation that is actually, and then the issue of quarantine that is restricting families to stay at home and all that. So getting to see if we're really prepared, I can definitely feel, yes, we know there is a need in terms of preparing ourselves to deal with mental health and psychosocial support, having systems in place, structures to work on that. And I can tell you at the national level, the Ministry of Health has also realized, the government has realized the need. And so as we speak, we have even a mental health and psychosocial support subcommittee where Kenya Red Cross sits as a co-chair. But you realize that that subcommittee still has a lot of steps to make. And one of the reasons why I'm saying that it has a lot of steps to make is that we want psychosocial support to be a service that can actually embrace like any other service, to be, for Kenyans to realize COVID has come and we need, other than looking at the normal healthcare system and how we can receive services, we also need to speak out. So the speaking out, the need to seek for support needs to be mobilized for Kenyans to know that I do not need to die alone. I do not want to self-stigmatize myself. I do not want to stigmatize my neighbor, but we can all talk. So while we have systems in place like the toll-free line, the 1199 that is being hosted by Kenya Red Cross, and many other partners have come up with the systems to support mental health and psychosocial support. For me, I think we need to do much more. And some of the ways we can actually do is to ensure that the same way we publicizing the numbers, which says these numbers, we have these numbers that are positive, we have these numbers that have recovered. We also need to have a follow-on message that says, in case of any support, any mental health and psychosocial support that you may require, please reach out to the service providers. And we have service providers in these places. There is a toll-free line, 1199, and any other toll-free line that will be provided by other partners. The second thing that we can actually look at is that how do we have like survivors? You know, when HIV came, we would see survivors coming on board. But in this case, other than the patient 1 and patient 3, we've not had champions coming out and saying, you know what, I was down there, but today I am strong, to just give a message of hope. So we are looking for a scenario where we can actually have champions to talk about COVID because they've gone through successfully and we can see the face, we can relate, and we can actually have the courage to support the other members in the community that may want that. The number 3 part that we need to be ready to do is that COVID has affected different cohorts differently. The children are affected differently. They're worried, will they finish school? Will they have to repeat? The youth are worried of staying at home. The working class are worried of different things. So even just getting to package messaging for the different groups, we are yet to get there. And I think that is why I'm saying we have begun, but we still have a long way in terms of readiness, because today, God forbid, if we had a serious surge like what you've seen in Italy, what you've seen in Spain, then you'd realize that the need for psychosocial support will be a mass. And so Kenyans should be ready. And I think before we get to that level, we need to have marketed, mobilized, and provided an environment where we can reach out for support, because then that also links to even the effectiveness of home care. Because unless we get to a level where we can support each other in the community, even home care will be an uphill task. You can imagine home caring your uncle, your niece, your nephew with a lot of stigma, and you have no one to call to, and your neighbors will not even say hello to you on the plot where you stay. So I think for me, I feel, yes, we're doing something, but much more effort, much more collaboration is required for us to get to a level where we can support each other. Because then as we support each other, then we even reduce other negative vices, like we are seeing gender-based violence really increasing at such a moment. So we really need to collaborate and be able to strengthen that, to sit at a comfortable face and say we can support each other through COVID. Thank you.
You've mentioned a lot of psychosocial support, so I'm still not going to let you go. Because it has provoked a number of questions here from Naomi again. What psychosocial support measures have been put in place for frontliners? Emphasis is usually placed on the community, but not on healthcare workers. And then a related question from somebody labeled Jose, number 2. Do we see any stigma in the healthcare centers of either COVID patients or fellow medical staff? So the first question, I'll give it to you, Miriam, and the second question, I want to give it to Josfrida and to Dr. Twahir on the issue of whether any stigma is observable. And I don't know whether here the question was talking about outward-facing stigma or self-stigma of COVID patients and fellow medical staff. So the first question to you, Miriam.
Yeah, thank you.
What is being done with regards to psychosocial support for healthcare workers?
Thank you. I think as of today, we can comfortably say we have trained over 500 mental health and psychosocial service providers who are actually professional counselors. And what we are doing is that we are organizing for what we call psychosocial first aid sessions for healthcare workers. So we have done this for healthcare workers as a Kenya Red Cross organization, for workers in Kenyatta Hospital, for workers in Bagathi. And I know that we already have plans to even do the same in workers countrywide. So we already have plans. We've trained the providers to be able to do virtual meetings and be able to provide the psychosocial first aid. And we have the healthcare workers sitting, being able to talk about their fears, being able to talk about their anxiety, and they're able to be helped through. Because as much as they are healthcare workers at the health facility, remember they also belong to a home. So most of their fears would really be around in carrying the infection back to their families and also just carrying infection within their peers at the work environment. So a lot is being done to the level where we can speak today. But as I can say that if we can all reach out to the other facilities that are not reached out, then that would be a plus for us. So it is in progress.
Okay, thank you. So to Dr. Twahir and to Josefrida, any stigma, self-stigma or outward-facing stigma in the health centers, you know, for COVID patients or fellow medical staff, particularly those dealing with the patients?
So as an institution that has taken care both of patients and as well as of staff, I can tell you very boldly that it's real. It's very much on the ground. The first few days into the COVID situation was worse. I describe this as a journey, so it's getting better. People, the anxiety, the fear between healthcare workers is much less. We are glad we are supported by a psychologist at the hospital. I can tell you she's been one of the busiest members of staff in the last 2-3 weeks. Right from people serving food to fellow colleagues, both in the nursing and in the doctor side, to administration. The stigma is very much there. We have had scenarios where, especially the first few days, people who go to serve food to some of these patients quickly present it to the doors and run away as the patient is about to pick up the food. You can imagine for patients who are fairly stable, it was really traumatizing, especially when it came to staff. It's peeling off. It's becoming less and less. And as we keep talking about this problem, we expect it to become much less. But it's really it's there on the ground. And I just wanted to reiterate what Miriam has said. She summarized it very well. I think we need to keep up the momentum to continue talking about this. It's not a death sentence.
Josefrida?
So yes, I want to agree with everyone. Stigma is there, and it's really not so welcoming, because you find first, for the health workers who tend to go to these health facilities, also get outward stigma from their own colleagues. and yet sensitization has been done to them and they have some bit of knowledge. You really wonder where all the knowledge went through. But I think it's a new experience and everyone would get worried about that. And also for us who've attended to the patients, like me being a team lead in the first isolation unit in Kilifi, then it was really tough because I think as it has been said, most of the attention is given to the community and preparedness for the patient, but preparedness for the health worker, for a moment, I think it gets forgotten. But this person really needs a lot of psychosocial support, because if your family already is worried that you're out there, your colleagues are already worried about you. The community also knows, okay, Frida works in the hospital and works in the isolation center. So then you become, it becomes a burden to you to be able to discuss these issues. And I think more sensitization should be done that, yes, it's true, as Dr. Twaish said, it's not a death sentence. I would just like to share one of the colleagues who went home and the spouse was like, no, you have to sleep on the floor. You can't share a bed with me because you've attended to a COVID positive patient. So I think, yes, and this psychosocial support, I would encourage it to happen earlier on as the program goes on, not when people are so into it, because then you have a lot of meltdowns that you get from the health workers, and still meltdown for the patients that you're having in isolation. Because you remember, in isolation, they're not as comfortable as they would be at home. Others also would not still understand why they should be in isolation, when maybe this issue of home-based care could work for them because the environment was allowing them. But for our cases, most of the cases we had, they had a lot of stigma from the community. In a bid, the facility and the county government had to come in, and it was a multi-sectoral collaboration to just evacuate them, because we had cases of patients even wanted to be lynched, leave alone the COVID positive, even the suspected cases. So I think there is a lot to be done. It's an emotional time in any capacity, family, work, you can mention it. I think this is a time that we really need to check on the psychosocial support that is required. But we are glad, as for Kilifi, part of the psychosocial support we got was you have a designated, as you work from the facility, you have a designated area of residence during your shift, because you used to do a two-week shift for 12 hours each. You have a designated place to stay during your time of work, and after that, you're able to go to quarantine at a designated place. So I think in a way it helped. And in the quarantine centers for the healthcare workers, we were able to get animators who would involve us in a lot of activities to able to just maintain sanity throughout the duration of time. Yeah. Doc, you're muted.
Oh, sorry, thank you very much for sharing that, for pointing that out. Maybe it's also getting to be part of Zoom fatigue. Maybe I need also this kind of support. Now, or home-based care. Now, Christina still feels, Christina still feels her question hasn't been answered well. She's still asking about the special population, people living with disabilities, terminally ill, elderly, etc., etc. These are people who will have challenges staying in quarantine facilities. How do you handle them? Should one of their family members get infected with COVID-19? Should home-based quarantine be recommended for them? This is more or less a policy question, if my interpretation is right. I don't know if you can take first dibs at answering this, Emma.
I can take an attempt because I think this is a very special case. I think it may have to be handled on a case-by-case basis, and I think the Ministry of Health has already put in place protocols to support this type of people, the interaction with the people who will come to investigate at the house, to check if the house is capable of handling home quarantine for these patients, and how to support these patients. So this actually is already operational from a Ministry of Health perspective. But I think there's no blanket statement for this special group of people. Back to you, Ben.
Okay, Miriam? Home-based care for people with special needs?
And
Should
my answer
should
will
they
be
get
equally,
infected? Mm-hmm.
yes, my answer will be equally similar to what Emma has said. I think we had the government in one of the press saying that we are actually considering the home-based quarantine for patients that would have been exposed. And that being the case, it only means that what they need is to finalize on the guidelines, and they should be able to execute that. So for me, one of the things I want to appreciate is that our government has actually taken up a learning path also, and you actually see them improving each and every day, because quarantine was outside your home. Now we are talking about consideration at the home, where they can actually come, they can do assessment, give you guidelines on how to operate, and have a healthcare worker coming to check on you as required by guidelines. So for me, it is already work in progress, and we really want to appreciate that bit of introducing the home quarantine by the ministry. Thank you.
Yeah, thank you very much for sharing that. It is also an appreciation of the fact that we need to stop thinking of health and medical care, and this is the subject of next week's webinar, so watch out for it, of thinking of these two things as being synonyms, as being similar, okay? Because with health is a much broader understanding, and care then therefore starts pretty much from the home before it even gets to the facility. And then depending on the chronicity or severity of the disease, then it might even end back doing a complete loop back again to the home in terms of end-of-life care and stuff like that. So this is an understanding towards that, and we appreciate that. But the fact that we are thinking about hospital-based care, home-based care, means that we are now thinking more long-term. And that then brings me to what might end up being my final question, given the time. So far we have been in the emergency phase of dealing with this issue. So we've been having emergency transport, emergency treatment centers, quick mobilization of staff, of equipment, quick formulation of standards, all these sorts of things. So we've, and to a large extent, this has really consumed us. And in a sense, the management of COVID has been handled as a special or a standalone kind of thing. But this cannot be sustainable. I have a question from Dr. Opot Eli that sort of links very much to that. Because his question was on any comments or ideas of assuring the public or patients who require care to stop avoiding health institutions during this period. Okay, what this means is that there's that interpretation. It has so consumed people that right now everybody knows hospital is only for COVID. Okay, we cannot sustain this in the population. It just cannot work. So, in my view, to have a more sustainable, a more long-term, or to take a more long-term approach, we have to find ways of integrating COVID control and COVID care into general health services. So my question to you, my panelists, and I'll give this to you maybe to take a chance in turn, how can we do this? What can we do to make this transition seamless, or this transition a reality? Are there any problems that you foresee, and how can we overcome those? And in this sense, I would want to start maybe Dr. Twahir, maybe you can kick us off, and then I'll take a loop around the participants.
So thank you. Guys, if you're feeling that COVID is going to go away, it isn't. This is the new normal. So at the end of the day, we need to adjust ourselves to accepting that it's a problem that will be with us for some time. More importantly is that we have seen scenarios in other parts of the world where stroke, cardiac issues the fact that people are shying away from going to the hospitals and therefore babies are not being vaccinated. And we're therefore expecting certain conditions to go up. We cannot afford to do this. So at the end of the day, we must marry the issue of taking care of what is apparent and vivid, that is the whole COVID issue, looking at COVID plus other morbidities, and just looking at taking care of the rest of the population. So we need to integrate this. And you're right, the biggest worry about patients is that are the hospitals safe? So many initiatives have been undertaken. What has been done, for example, at the Aga Khan Hospital, Mombasa, we have had various sessions of Facebook live scenarios where we actually explain to our clients how we have taken their safety as a priority. Naturally, they will come into the hospital and see how we have probably over-prepared. And I gave you the scenario of how our staff are putting on universal PPE as a routine. So that should give them confidence that we're not only looking out for our staff, but we are looking out for them as well. The other issue was, life has to go on. So at the moment, and I liked yesterday's comment from the ministry, is that should we start, for example, testing everybody for COVID? So why are they looking at this scenario is to have some continuity of care. We have a cath lab, for example. We have a theater that right now is performing under par because people are shying away from coming to hospital. So how do we give some comfort zone to patients and then also to the staff who are going to take care of patients, so that either one of them feels safe enough to have continuity of care. So paramount for me is to communicate, and every institution should go out of its way to reach out to the people they've been taking care of, to inform them that the hospitals have taken an extraordinary step to make themselves safe. We have, for example, separated our outpatient department from the hospital, so that we try and keep away inpatient care away from outpatient care. Again, try to keep safety of the patient as a priority. So this should be our dictum, that we reach out to our patients. We have a cohort of cardiac patients. We have a cohort of diabetic patients. If we don't take care of them, they will come down very sick, too late for anybody to respond. And then, of course, reassuring them about their safety. I think for me, that's the most important thing. Communication. That should be our response, and reaching out to our clients, reassuring them that the hospitals are safe enough for them to come to the hospital. Otherwise, we'll see an explosion of the NCDs.
So in brief, what you're saying is, yes, COVID is not going away. So we definitely need to find ways of transitioning this. I gave an economic argument by stating that, running COVID programs right now as campaigns in the way they are very costly. Standalone interventions, usually are not sustainable on that basis. And you bring in an interesting point. One, we need to go out there to the community and do two things. A is to demystify what COVID is, and the second bit is to assure them or meet them at the point of need in terms of assuring them that hospitals are still safe environments, and they shouldn't shy away if they have these other needs. Okay, fair enough. Maybe Emma, how do you think we can make this transition? What problems do you foresee?
So first, I'd like
in making this transition.
Okay, thank you, Dr. Ben. I think I agree with what Dr. Tahir has said in terms of community outreach and community engagement, demystifying the disease, and supporting the patients to know that there is continued care at the hospitals. But additionally, one of the areas that we should focus on in terms of moving forward is how the hospitals adapt to what life looks like in the long term with COVID. And this could either be physically in terms of what Dr. Tohir has actually mentioned in terms of separating the hospital. So you're able to assure patients that one area actually handles COVID patients, whereas another area will handle continuous care for different types of patients, whether it's pediatric, maternal, non-communicable diseases, that they are safe and protected, you know, with the hospital instituting the right infection prevention protocols. But furthermore, facilities also need to think differently about how to still have the same engagements and touch points with these patients. So whether that means digitally, calling them, telehealth, whatever options are available for facilities to still ensure the continuum of care. Some of the problems I think moving forward, even now in the short to medium term, is really around the stigma that everybody has mentioned on the panel. Until we're able to deal with a lot of the stigma, even in the community, we will not be able to test adequately and therefore be able to know what is the real picture of the disease in the country and therefore how we can support continued services. So we really need to handle the stigma question very well for the community and for healthcare providers so that we can able to test and treat the relevant patients and ensure that everybody in the community knows how these two people are being kept separate. I think those are important things to think about, especially in terms of challenges.
Okay, thank you. There are some other challenges also that I foresee, and this one I want to sort of peg on to maybe Miriam and to Josefrida and Dr. Nzomo there. You know, there's this perception, or maybe it is real, whenever you're operating or you're running something as a standalone or as a campaign, as we would like to call it in public health, the cost elements are usually high. And part of the reason why they're high is that either you are taking on new staff. In the case of Kenya Red Cross, maybe you've taken on new volunteers, you have a new COVID program officer, I don't know, or something like that. In the case of facilities, maybe in Kilifi there, you might have staff who've been put in place, now earning special allowances, getting access. So you know, and transitioning or integrating would mean that this special status is somehow lost. People don't take kindly to losses. Are you foreseeing this as a challenge, and what can we do to minimize these kinds of things? Just Frida or Dr. Nzomo, you can start.
I think, yes, these are some of the challenges we face. And as we've all agreed, it's a new thing that needs to be considered for various reasons. But looking at the bigger picture, today you didn't think you'd stick with a mask the whole day. Or just like not have social gatherings and stuff. So I think it's a process, and it's something we have to move with a lot of intellect, and also people should come into agreement with whatever is happening currently. Because I think like in our government facilities, we had more posting orders that, you know, it's out there, you have to go and work. And I think the allowances, maybe I would put it as a reasoning to just be able to give some social support to the health workers, psychosocial support, to feel like, okay, maybe whatever I'm doing is being appreciated. But the truth is, if I think we go back to the community and look at the numbers in our mortality rates, I think we've gone a bit higher because of the other comorbidities that people are having in the society that are not presenting to the hospital. So I think it's very much important to integrate these services, but as it is, we should be in a position to actually separate the facility to ensure that the patients are still safe, and we're also safe taking care of the other patients in the society. And as it is, as a standalone, we tend, it's true, in the long run, we may run a very big loss, because of all these incorporations that we are running in right now. As you said, we're acting as an emergency thing in the society. So I think it's good to just look at the challenges, and I think people will not take it lightly, but if it's for a long term and sustainable, you look at sustainability of a program, then some of these things have to be taken care of and foreseen as they are. I know it's going to be difficult, but I think something will have to work itself out.
Okay, thank you for that. I'll ask Miriam very, very quickly, because now my time is up. How, how is the Red Cross preparing for this transition? Right now, there's a lot, there's COVID money, everybody's mobilizing, but this is not a sustainable model. We are going to be here for the long term. How are you preparing for the long term? Very, very briefly. Much.
Yes,
so that I don't
and
I
can confidently tell you that Kenya Red Cross is already doing an integrated approach. So most of our programs are actually not just COVID specific, but we've ensured we've included that. So the element of service continuity is part of what we are doing. And we've done that even as we, in Nairobi as we speak, we're even doing outreaches alongside COVID response. So that is what we are doing from our end. We did not disaggregate the two.
Okay, thank you. Thank you very much for keeping it brief. Ladies and gentlemen, our time is up, but please allow me to just reiterate one or two things that I think, I hope we were able to take out of today's conversation. Number one, COVID is real. We've had it from people who are experiencing it, at least from the perspective of caring, preparing institutions or managing institutions that are in the front lines of care for people who have unfortunately contracted the illness. But the idea of control is not to be left only to institutions such as the ones that we've been talking to today. Control is something that all of us can be able to participate in. We can all participate in control measures that are directed towards, minimizing infection, the issues around antiseptics and sanitizers, reducing transmission through quarantine or isolation, and so on and so forth, better personal hygiene, etc., etc. And that way, we can sort of minimize the pressure that is within the facility so that the facilities can better take care of those who actually need them. The second thing that I hope we were able to take away is that we need to start thinking a lot of from moving from these emergency kind of responses towards preparing ourselves for a long-term prevention. And some of these will involve, of course, preparedness at all levels, both from the communities all the way up to the caregivers. But at the same time, integration, okay? And for these institutions or these frontline workers to start thinking of how they can integrate these kinds of responses into their routine work, all right? So thank you so much, ladies and gentlemen. Thank you, panelists, for ably presenting, I hope, on this forum. I want to thank the participants for the very good questions and comments that have been put out there. But before we sign off, I want to just remind you that, excuse me, next week, we will be looking at a different aspect, and we will be sharing that with you. I can see there's something already on the screen there. So please take note of that. And before you leave, we would really appreciate getting your comments, the utility, if any, of this webinar, whether you found it useful, whether you found it informative or otherwise, and if there's anything else that you would want us to consider. I also want to encourage you to join me in appreciating our panelists for sparing their time and sparing their insights, and kudos to you, and kudos to you, the panelists, and your institutions for what you're doing. But then also kudos to the rest of the participants, whom I hope are playing their part in controlling or bringing to the epidemic to control. Thank you very much. Have a good evening and God bless. Asanteni sana. Bye-bye.